Hello, this is Dr. Dickerson. This is a voiceover over Chapter 23, the Musculoskeletal System, since you didn't get a full lecture. A lot of this you guys have gotten already in A&P, but I want you to be aware the musculoskeletal components, the bones, cartilage, ligaments. Bursa is an important one. It is the enclosed fluid-filled sac that serves as a cushion. A lot of patients will get what's called bursitis in these areas. They'll get the inflammation in the bursa sac, like behind their kneecap or their hip area. It's very painful, and generally they have to have an injection into the site to make the pain stop. I want you guys to be aware of these terms, not only for exam purposes. You might see them on the NCLEX, you might see them in practice when you're reading different types of charting. So flexion extension, abduction, if you think about away from the body, so think about a child being abducted, they're away. Adducted is towards the body, think about addition. Pronation, supination. Supination, I remember I told you in class, pretend like you're holding soup in your hands, so your hand is upward. And then circumduction. Again, these are very important terms for future and for, of course, testing or NCLEX purposes. Same thing on this slide, just keep in mind the different movements, inversion, eversion, rotation, protraction, retraction, elevation, and depression. Those are all things that you might see in charting purposes. Hard to remember different types of definitions, so just briefly, go over them. If you're good at memorization, make some note cards or something. Big one in the shoulders, the rotator cuff. A lot of patients will have a rotator cuff injury. We'll discuss this later on in the PowerPoint, different types of tests that you can assess for rotator cuff injury. The knee is stabilized by two sets of ligaments. The cruciate, which is anterior and posterior stability, helps control the rotation. And then you have the collateral ligaments. They give the medial and lateral stability and prevent dislocation. So if you're thinking of the MCL and the LCL, that's when you're talking about the collateral ligaments. In the older adult, we are always concerned about osteoporosis. They start to have postural changes and decreased height. Kyphosis has a slight flexion of the hips and knees to compensate. So kyphosis is the term. When you look at the elderly, that's how their posture looks. Distribution of subcutaneous fat changes leading to a different contour. So they start to lose the subcutaneous fat, so their bony prominences are more noticeable. Also, that's why the elderly, they'll start to get more sores over those bony areas. They just don't have as much fat as they did when they were younger. There's an absolute loss in muscle mass, so size and atrophy starts to produce weakness, which is why it's so important for the elderly. They need to start, do their walking, and then it's an impact on their sedentary lifestyle. A big thing to decrease osteoporosis is exercise. but not just exercise, but weight-bearing exercise. You want your patients who are at risk of osteoporosis or have osteoporosis to do more weight-bearing exercises to help with the process. So obviously you guys can read this through, this is just some subjective data that you might collect related to the joints, knees, muscles, bones, ADLs, patient-centered care. So you want to be touching on what type of ADLs they're able to do without any help, or if they have their daily living activities, they're having people help them throughout the day. There are multiple functional assessment tests that I'm going to discuss throughout this lecture that are important. You want to look over those and understand the differences. There are several different ones that you produce with the elderly, so that you can better understand what they're capable of doing at home, or if they needed to be in assisted living or have somebody that's helping them out on a daily basis. These are just some health history questions that you might ask related to the joints. So any problems with their joints or pain, where it's located, what joint's hurting, if it's on one side or both sides, the quality of the pain, what's it feel like? Is it an aching? Is it stiff, sharp or dull? Is it a shooting pain? How severe is it? When did it start? When does it start? Do they wake up with the pain? Do they go about their day and the pain starts to worsen throughout the day? Does it start in the evenings? What type of day does it start? How long does it last? When does it occur? Is the pain aggravated by movement, rest, position, or weather? So if they're not doing anything, do they have pain? Or if they're having pain and they stop doing that, does that pain alleviate? Is it alleviated with medications, ice, or heat? Does it have chills, fever? Have they been sick recently? Any trauma? Are they stiff in those joints? Is there heat or swelling or redness in those joints? Do they have limitations in their movements? What activities give them problems? Are they able to do their ADLs? Joint pain and loss of function are the most common musculoskeletal concern that prompt a person to seek healthcare. I added this slide in here. This is important just because a lot of people get rheumatoid arthritis, osteoarthritis confused, or they might not understand them completely. So rheumatoid arthritis is worse in the morning when the patient wakes up. It involves both joints. Osteoarthritis is worse later in the day. So they might wake up fine, but they start to have pain later on in the day. Tendinitis is worse in the mornings and it starts to improve throughout the day. Movement increases most joint pain except in rheumatoid arthritis, in which movement decreases the pain. So the more they move, the less pain they're going to have. Joint pain 10 to 14 days after untreated strep throat suggests rheumatic fever. So if a patient's had strep throat and say 2 weeks later they're seen in the clinic complaining of severe joint pain, they might actually have rheumatic fever, and there's a different type of treatment mechanism. You know, the strep's gotten a lot worse. Joint injury occurs from trauma or repetitive motions. When a patient presents with joint pain but they've got no other issues behind that joint pain, or it's a new onset joint pain, you might want to ask about a tick bite. So that can help identify the reason behind pain in a previously healthy individual. So you'll test for Lyme's disease. It's the most common one in our area. Rocky Mountain spotted fever is also common, but the Lyme's disease will cause the severe joint pain. So I also included in here the differences between the MCL, the LCL, and the ACL. So the MCL and the LCL are those ligaments on the inside and the outside. MCL is the inside of the injury and can strain or rupture, and then the LCL is the outside injury that's a strain or a rupture. And then the ACL is anterior, so say in front of, or right around the front of the knee, when you're talking about those cruciate ligaments. So when we're asking health history questions on the muscles, you want to ask about different locations or cramping. So is the muscle pain more of a cramp, or is it a severe pain? Is it a shooting pain? Is it stabbing? Do they have more when they walk or when they're sitting down? What's the quality of the pain? Does it feel like it's aching, stiff, sharp, dull? How severe is the pain? When does the pain start? Does it start in the morning? Does it start in the afternoon? What time of day is it? Is it alleviated with anything? Medications, heat, rest. Is it aggravated with movement, pain, movement, rest, position, or weather? Is the pain associated with any fever, chills, recent sore throat, any recent illness, trauma, repetitive movement? You want to ask about swelling, heat, stiffness. What activities might give the patient problems? Are they able to get up throughout the day? Are they able to do things at home? You want to think about the weakness and the size. So compare each muscle. Is one muscle much larger than the other? Is it severely atrophied? Ask about any weakness in their muscles. Then when you're asking health questions about their bones, same thing, pain at rest or movement. Does it aggravated by movement? The more they do, the more pain they have. Do they have any deformities due to injury or trauma? Does this affect their range of motion? Have they broke their wrist before in the past and have severe pain since then? Do they need to have some sort of operation to help fix this? Any accidents or trauma that might impact those bones? Any residual deficits from, like I said, a broken wrist or surgery in the past? Any back pain? Back pain is a major, major problem with patients. They'll come in complaining of back pain. They can't do certain things. It makes them they want to lay around all day. Any neurological or physical deficits? Any recent trauma? Very recent. Are they runners? Do they have what's called just like a minor fracture or something? So the first assessment I'm going to discuss is functional assessment of ADLs. So you want to ask the patient about their joint problems. So is it bone, muscle? What is it limiting on for them? So is it limiting their ADLs, and what ADLs is limited? So can they get dressed on their own? Can they brush their teeth? Can they shower? This screens safety of independent living, or for if they need home services, if they have a good quality of care, if they're getting the correct care. Is it affecting their life drastically at home? Would they be better in an assisted living area? So you're going to ask specific questions about bathing, toileting, dressing, grooming, eating, mobility, and communicating. Are they able to call people? Are they able to prepare their own meals? If they're unable to prepare their own meals, how do they get their meals? Do they order meals? Are they able to eat on their own? So they're able to use silverware, go to the bathroom, take a shower. So if they're constantly soiling themselves because they can't get up, is this affecting their everyday ADLs, and what's affected and how often, when it is, stuff like that. When you're assessing the aging adult, you want to use the functional assessment history questions to elicit any loss of function, self-care deficit, or any safety risks that they might have. Any new onset weakness, any history of weakness. Are they falling more, stumbling? Are they using a mobility device, so a cane or a walker? Are they able to get around without that cane or walker? And then DEXA screening is recommended for females ages 65 and older. So obviously you already know the order of examination when you're performing your head to toe. You start with inspecting, then palpating. Here I want to discuss range of motion. You want to ask for active voluntary range of motion while you stabilize the body area proximal to that being involved. So if you see any limitations, gently using the passive range of motion. You want to assist the patient with stabilizing their body so that they're able to move their joints around. Rotator cuff lesions may cause limited range of motion, pain, and muscle spasm during abduction, while forward flexion stays fairly normal. So on the hip, you're going to inspect the hip joint together with supine later in examination as the person stands. So you want to see if it's symmetric, levels of the iliac crest. So you want to look behind as you're assessing your patient. You want to look at them from behind, assess if their iliac crests are equal, their gluteal folds, equal size buttocks. A lot of times that'll help you assess if maybe they have like an SI issue, if they've got their hip in and out, stuff like that. Help the person into a supine position, and you're going to palpate the hip joints. They should feel stable and symmetric with no tenderness or crepitations. And then you're going to assess range of motion. So the limitation of abduction of hip while supine is the most common motion dysfunction found in hip disease. So that's pretty important to remember as you're assessing your patients. So with the aging adult, as I discussed earlier, their postural changes include decrease in height, more apparent in the 8th and 9th decades. Kyphosis is common with backward head tilt to compensate. Contour changes include a decrease of fat in the body. Bony prominences are more marked. You want to assess range of motion. You want to perform a get up and go test to make sure that they're able to actually get up and out of a chair. And then, of course, the functional assessment of the ADLs. This is an important slide as well. It just has some definitions, medical terms here that I want you guys to be aware of. Obviously, you know what a fracture and a dislocation are. Subluxation, contracture, shortening of the muscle leading to limited range of motion, and then ankylosis is stiffness or fixation of a joint. So just be aware of what these terms mean. So rheumatoid arthritis is a chronic inflammatory pain condition, possibly started by an autoimmune response, inflammation, or some sort of infection. The inflammation of the synovial tissues, hyperplasia, and swelling leads to fibrosis, cartilage and bone destruction, which limit motion and show as deformity. Joint involvement is generally symmetric and bilateral with heat, redness, swelling, and painful motion of affected joints. RA symptoms include fatigue, weakness, anorexia, weight loss, low-grade fever, and lymphadenopathy. RA carries increased cardiovascular risk of heart attack and stroke. So when you're thinking about rheumatoid arthritis, when you're thinking about autoimmune issues, then you're going to think about all of those symptoms that come with those autoimmune issues when you're trying to remember what type of signs and symptoms your patient might have. Then we've got ankylosis spondylosis. It's a chronic inflamed vertebrae that is extreme form leads to bone fusion of vertebral joints, which is the ankylosis term. So joints are usually fused together. They're not able to say it's in your wrist. Your wrist and your fingers might have issues moving. They might be stuck that way. It affects the spine, pelvis, and thoracic cage, and is characterized by inflammatory back pain that is dual and deep in lower back or buttocks. It has morning stiffness that usually lasts greater than 30 minutes and decreases with activity, nighttime wakening with pain. So the more they get up and move throughout the day, the pain decreases. Spasm of paraspinal muscles pulls spine into forward flexion. So if you've ever looked up a picture of a patient like this, it's very noticeable. When you're thinking about the term again, ankylosis, they're just really contracted almost. Obviously, you guys can read this slide, osteoarthritis and osteoporosis, and what's on there. I just want to briefly touch on osteoporosis. As I did previously, discuss the physical activity. You want to have your patients doing weight-bearing activities. It delays or prevents bone loss in perimenopausal women. So even fast walking, if they are using some sort of weights, that will help them drastically. um, Annually assessing the bone density scans does not prevent osteoporosis, it just helps monitor it. And there's no medications to prevent osteoporosis, but just to treat it when they're on like the calcium and the vitamin D, but they have to be on pretty drastic doses. So I want to briefly touch on the swan neck and boutonniere deformity. So flexion contracture resembles curve of a swan's neck as shown in that picture. Then hyperextension of the PIP joint and flexion of the DIP joint. It occurs with chronic rheumatoid arthritis, often accompanied by the ulnar drift of the fingers, as shown in that picture. And then in boutonniere deformity, the knuckle looks as if it's being pushed through a buttonhole, and it's a common deformity. So just remember those two terms are related to rheumatoid arthritis. Then on this slide, I wanted to talk about osteoarthritis and what type of deformities you might notice. So different from rheumatoid arthritis, it's characterized by hard, non-tender, non-inflammatory nodules. These growths are called Heberden nodes, and then they've got the Bouchard nodes, which are less common. So just remember those two terms related to osteoarthritis, and then just study over the rest of this section here that I've included from your text. So that is